I am going to address which heart rate provides the optimal cardiac output in various conditions. This is a highly relevant question in our everyday practice, yet, as you will see, it is difficult to answer and there are no specific guidelines for the most part. I will provide you at the end of the presentation with a slide that summarizes the heart rate targets in various disease states. I will start with this very basic equation. Cardiac output equal heart rate multiplied by stroke volume. This simply implies that cardiac output rises with a rise in heart rate up to a certain point. And the key of the whole discussion is what is that specific point in various disease states and various conditions. In fact, stroke volume is dependent on both contractility and preload, both of which are affected by heart rate. Therefore, the effect of heart rate on cardiac output is very much influenced by what happens onto contractility and preload. To give you a simple example, if someone goes into tachyarrhythmia of over 200 beats per minute, the heart rate is dramatically up, but the preload will go dramatically down, overwhelming the rise in heart rate and leading actually to a hemodynamic collapse. I will start by discussing what happened at rest in normal individuals. So in normal individuals, an increase in heart rate is associated with an increase in myocardial contractility up to a certain point, even at rest. This is called the Bowditch or Treppe phenomena, and this will further help to improve the cardiac output. However, beyond a certain point, one, contractility stops increasing. There is a limit to that Bowditch phenomena. And two, the increase in heart rate at rest is accompanied by a reduction in preload because of a reduction in diastolic time, and this may lead to a reduction of LV stroke volume. This is particularly true in preload-sensitive patients on the upslope of Starling curve. This is the Frank-Starling relationship, which is cardiac output versus preload volume, not pressure volume, LV and diastolic volume. If you are a normal individual and you are at some point on the steep upslope, you are more sensitive to preload reduction by arresting tachycardia compared to if you're here up on that curve. Therefore, if you are here, you are more likely to not raise cardiac output despite a rise in heart rate and contractility. The drop in preload is dramatic enough to counteract the rise in contractility and the rise in heart rate. This explains why the butamine stress test can cause hypotension in hypovolemic patients on the upslope of the Starling curve. Therefore, to come up with a number that attests to that balance, at rest in normal individuals with no heart failure, cardiac output probably keeps rising until a heart rate of about 130-140 beats per minute, then starts declining. That number is likely lower, is definitely lower with hypovolemia and older age, as the elderly has lower contractility reserve. I will move on to describe what happened during exercise in normal individuals. During exercise, unlike rest, venous return increases. Ventricular preload increases on that Frank-Starling curve. We are using that Starling curve to our advantage. That's the essential difference between the tachycardia that occurs at rest that may be inappropriate and the tachycardia that occurs during exercise. The main difference is the rise in the preload, which allows the stroke volume to rise during exertional tachycardia. Stroke volume can rise up to 30 to 50% with maximal exercise. Then it stops rising, but it remains significantly higher than baseline. Most of the rise in cardiac output during exercise is provided by heart rate, which rises 2 to 3 times, but it is also helped by a rise in stroke volume. Therefore, cardiac output continues to rise with a rise in heart rate up to the maximal heart rate, which is generally around 220 minus age, in that neighborhood. Just a note in case you're wondering, how does venous return rises with exercise? Venous return rises because the increased skeletal muscle contraction pumps the venous return back to the heart. Furthermore, the higher arterial flow to the metabolically active tissues eventually gets dumped in the venous circulation and raises the venous return. I will move on now to more complex situations, and I will start with a specific case of systolic heart failure or heart failure with reduced EF. In this context, the maximal cardiac output seems to be achieved with a heart rate of 100 to 110 beats per minute at rest and with exercise in sinus rhythm or in AFib. Beyond this rate, cardiac output often does not rise and may decline. This is not because of a reduction of diastolic filling beyond this rate of 100 teens. In fact, as we see on the Starling curve, heart failure patients are not that preload dependent, and unless they are here and they are very well compensated, you can actually, when they are here at the flat portion of the Frank-Starling relationship, you can actually reduce their preload quite a bit without reducing their cardiac output. They have limited preload reserve and limited capacity to increase their cardiac output by increasing preload. In fact, they benefit from preload reduction for the most part. Therefore, it would seem that raising the heart rate in those patients with limited preload and stroke volume reserve would be critical to increasing their cardiac output. The fact that a rate higher than 120 was not beneficial reflects the loss of the Bowditch phenomena in this energy and metabolically depleted systolic heart failure patient. So their contractility starts to decline progressively, then dramatically beyond a certain heart rate because they are energy and metabolically depleted. This is the data for all those ideas I'm discussing in heart failure with reduced EF. Those are the 3 Bowditch revisited trial, excellent landmark studies from the United Kingdom. I will go over one of them quickly, the second and the third one. They basically took patients with low EF, older age, 72, and pacemaker dependence. They paced them at various rates at rest, and they assessed contractility at various rates echocardiographically. The heart rate with peak contractility was 103 plus or minus 22 in heart failure with reduced EF versus 126 plus or minus 15 in matched age-controlled patients with no heart failure. Also, the slope of contractility rise with heart rate was slower in heart failure. Very importantly, programming the rate response to the slower peak rather than a high peak of 140 led to more exercise time and higher peak O2 consumption. 28% of patients had AFib, and this did not seem to affect the peak heart rate for peak contractility. Effects were sustained at 6 months. The lower heart rate was associated with a superior exercise time at 6 months and no EF deterioration versus worsening of EF with a standard pacemaker settings. Therefore, the best cardiac output and the best peak O2 consumption are achieved at a rate of 100 to 100 teens beats per minute. This is an acceptable rate in exercise or heart failure decompensation. Yet, keep in mind, that's not the goal in a chronic setting. The goal heart rate at rest is less than 70 beats per minute at the compensated stage of sinus rhythm heart failure with reduced EF. This has been established from beta blocker trial data, which suggested lower mortality with achieving a heart rate less than 70 beats per minute at rest. This has also been demonstrated in the HFrEF trial, which randomized systolic heart failure patient to a pure sinus node slower called ivabradine versus placebo with a goal heart rate less than 70. Reducing heart rate reduced heart failure hospitalizations. Heart failure that is compensated and in sinus rhythm is the only condition that benefits from a tight rate control less than 70 beats per minute at rest. I will now move on to the specific case of heart failure with a preserved ejection fraction. Contrary to prior teaching, Such heart rate reduction less than 70 beats per minute has a questionable merit in heart failure with preserved EF and in atrial fibrillation, where actually a heart rate of 80 to 100 beats per minute may be acceptable and even optimal. Here is the explanation. In heart failure with reduced EF, mechanical and energy reserves are reduced. Therefore, contractility and exercise capacity paradoxically improve with lower peak heart rates. Conversely, in many heart failure with preserved EF subsets, particularly the most restricted ventricles, the stiff and small LV cavity has limited capacity to fill at slower heart rates, even in a compensated state, and may fully rely on heart rate to maintain cardiac output. This is what we call the limited preload reserve. And in this case, unlike heart failure with reduced EF, which also has limited preload reserve, the Bowditch phenomena may not be exhausted in the preserved EF setting. Therefore, that explains why pure heart rate reduction with ivabradine has improved exercise capacity in heart failure with reduced EF, but has worsened it in two trials of heart failure with preserved EF. These patients have limited capacity to use the Frank-Starling curve. You give them more time to fill, they are going to waste that time and are not going to fill more and increase the stroke volume. This is the diastolic filling of a severely restricted heart failure with preserved EF at a baseline heart rate of, let's say, 70 beats per minute. And this is the restricted left ventricle. And this is the diastolic filling, E, which is very brief, and A. If you slow down the heart rate to 60 beats per minute, the stiff LV does not fill more. Its pressure shoots up after that brief E wave, and it cannot fill beyond that brief E wave. You rather now have a dead space in diastole where no filling happens and where stroke volume is unchanged. That LV remains of the same size regardless of how much you slow them. It's not going to fill more. In fact, a faster heart rate of 80 to 100 beats per minute allows more LV filling overall per minute and more cardiac output via providing more cardiac cycles. And here is more data regarding the value of a higher heart rate at rest and with stress in heart failure with preserved EF. One trial suggested that beta blocker withdrawal improves functional capacity in HFpEF with resting heart rate less than 75 beats per minute and chronotropic incompetence, the preserve heart rate trial. Two other trials, mainly the MyPace trial, suggested that higher baseline pacing rate in heart failure with preserved EF patients with pacemaker, 75 to 80 baseline pacing rate versus 60 beats per minute, improves quality of life and BNP and reduces the risk of atrial fibrillation. And here is some pathophysiology data. Moderately high heart rate up to 120 beats per minute in heart failure with preserved EF enhance LV contractility and accelerate relaxation kinetics, particularly as the LV operates at a smaller volume, this red pressure volume relationship instead of the blue one. So the LV will operate at a smaller volume and therefore at a more compliant portion of the pressure volume relationship. This is not a lusitropic effect. That pressure volume relationship, the blue line, is still the same and it remains steep. It's just that when you reduce LV preload and volume, you're operating at a more compliant portion of that curve. The whole rectangle is shifted down and to the left at a more favorable pressure volume point. So up to rates of 120 beats per minute, relaxation kinetics may accelerate and diastolic pressures decrease in heart failure with preserved EF. Beyond 120 beats per minute, lusitropy may get impaired and cardiac output may decline. Also, a higher heart rate over the long term in heart failure with preserved EF by reducing preload and central aortic pulse pressure and afterload, meaning by unloading that left ventricle,
may induce eccentric LV remodeling with a reduction in ventricular wall thickness and stress and a more favorable left ventricular mass to volume ratio and an improved ventricular compliance over the long term. And this is the data, those 7 papers supporting what I said. I particularly like this paper here. This study took myocardial samples from cardiac surgery patients and analyzed their response to in vitro pacing. Half the hearts displayed normal complete relaxation upon increased pacing from 60 to 180 beats per minute. The other half, which had heart failure with HFpEF clinically or LVH or high to E prime on baseline echo, displayed incomplete relaxation starting at a rate of 110, 120 beats per minute and worsening with higher heart rates.
I will move on now to the specific case of atrial fibrillation. Atrial systole contributes to 20 to 40% of LV filling and stroke volume, more so in stable heart failure, which has a large A wave on echo Doppler, and less so in decompensated heart failure with a tiny A wave on echo Doppler. With the loss of atrial systole, stroke volume declines and cardiac output risk declining by up to 40% at a similar heart rate. Therefore, if a patient under the same condition goes from sinus rhythm to atrial fibrillation, the heart rate must rise to maintain cardiac output. AFib rate has to be higher than sinus rate. This explains why aggressive rate control in AFib to a rate less than 80 beats per minute has not been more beneficial than lenient rate control of 80 to 110 beats per minute, according to RACE-2 trial, which has been adopted by the ESC guidelines. Even in heart failure with reduced EF, when the patient is in AFib rate control less than 80 beats per minute has not been shown to be beneficial based on beta blocker trials meta-analysis. The same sort of analysis that showed that a low rate less than 70 is useful in heart failure with reduced EF in sinus rhythm, not AFib. Beyond the effect of loss of atrial contraction, in AFib, the irregular rate by itself further reduces cardiac output. In fact, LV filling and stroke volume sharply and exponentially decline with a short RR cycle length less than 500 milliseconds, which corresponds to a rate over 120 beats per minute, while they more gradually increase with lengthening of the RR cycle length up to 700 milliseconds, which corresponds to 85 beats per minute. The very short RR interval, less than 500 milliseconds, reduces stroke volume more than the long RR interval over 700 milliseconds makes up for it. RR intervals that swing between less than 85 and over 120 beats per minute are particularly harmful for the cardiac output. This is particularly related to the inefficient preload times heart rate at those levels, but also to the excessive calcium mishandling with irregular rhythm, leading to inefficient and reduced LV contractility. Let's take a regular rate of 90 beats per minute, and let's make it irregular in 2 fashions, 2 and 3. It's the same rate, 90 beats per minute, but it's irregular. Changing from a regular to an irregular heart rate can reduce cardiac output by about 15 to 20% even for the same rate, and can increase wedge pressure by about 20%. This is particularly true when the RR interval vary between less than 500 milliseconds and over 700 milliseconds, meaning that the rate is varying between less than 85 and over 120 beats per minute, even while averaging 90 beats per minute. This is particularly the case when you have a long-short sequence, as you see under 2. As such, the cardiac output is lower for the irregular rate under number 2 than it is for the irregular rate under number 3. In fact, a long-short sequence such as this one here or this one there may lead to a pulse deficit on that beat that follows the long-short sequence. The long RR sequence empties the ventricles fully and is followed by a short RR interval on an empty underfilled ventricle that generates no stroke volume. A similar process is seen in patients with PVC by Gemini and is equally harmful. So striking irregularities can lead to striking pulse deficits and a striking reduction of cardiac output for a similar rate. Those concepts have been proven in two excellent landmark analyses of irregular heart rate published in the 90s. This explains why trials of atrial fibrillation ablation in heart failure with reduced EF have consistently shown a rise in ejection fraction of 10 to 30% after ablation, and frequently normalization of EF, mainly in persistent AFib, even in patients whose AFib rate is controlled. The first two trials have shown an improvement in EF, but also a reduction in mortality with AFib ablation in heart failure with reduced EF. The other two trials have shown dramatic increase in EF with AFib ablation in heart failure with reduced EF. This is a hemodynamic study I performed and consists of simultaneous LV and wedge pressure recording in a 76-year-old female with atrial fibrillation and restrictive cardiomyopathy. This is her wedge pressure at rest, and this is her heart rate, AFib rate 78. She has a prominent V wave and mildly increased mean wedge pressure at rest. I performed here mild arm exercise, and with that V wave dramatically rose to about 45 millimeter of mercury, as you see under the red waveform. And this happens because the stiff restricted left ventricle and the non-compliant left atrium are overwhelmed by the tiny rise in venous return from her tiny amount of exercise. This is not mitral regurgitation. This is just overwhelmed heart failure and restrictive cardiomyopathy. Note that her heart rate is 88 during this exercise and this very large V wave. So what I did here, I gave her isoprel infusion and allowed her AFib rate to rise to close to 105, 110 beats per minute while doing the same mild exercises. You can see that her wedge pressure significantly improved and her V wave dramatically declined from 45 to barely 20 with a faster heart rate. In fact, her V wave declined even compared to the resting condition. This is a reflection of the improved cardiac output and the improved overall left atrial emptying and LV filling via increased number of emptying cycle. This shows how the increase in heart rate and AFib rate of 107 compared to 78 or 88 significantly improved the hemodynamics of this patient with atrial fibrillation and heart failure with preserved ejection fraction. Regarding the optimal heart rate in atrial fibrillation, both the prior concept as well as an echo study performed by Rowles in 1990 suggest that the maximal cardiac output in AFib is achieved with a AFib rate of 100 to 120 beats per minute, depending on the preload.
Now, regarding heart rate in valvular disease, one mitral stenosis, the target heart rate is less than 70 to 80 beats per minute, even in decompensated heart failure from MS. Because in MS, the gradient is very dependent on heart rate and can dramatically rise with faster rate as diastolic emptying time declines. So when you become tachycardic, the diastolic time declines and the gradient will rise as you have less emptying time. And in fact, diastole shrinks not only per cardiac cycle, but it also shrinks on a per minute basis. So in tachycardia, diastole shrinks on a per minute basis, whereas systole expands on a per minute basis. Thus, MS is one of two conditions where acutely slowing the heart rate in the midst of pulmonary edema can actually be helpful. The other condition being HOCM, where the obstruction is dynamic and worse with higher inotropism and lower preload. Now, regarding other valvular disease, decompensated AI needs a higher heart rate because that higher rate will provide a higher cardiac output. Also, higher rate induces less diastolic time and therefore less AI volume. Also, decompensated AS and decompensated MR need higher heart rate to increase cardiac output. So aside from MS, the other three valvular diseases need higher heart rate. However, as it is with heart failure with preserved EF, higher heart rates over 120s may become counterproductive because of Bowditch limitation and lusitropic limitation beyond 120s. Now, specifically for AS gradient during hemodynamic study, that's a question that comes up often. What does tachycardia do to the AS gradient? Tachycardia is associated with an increase in inotropism up to a certain rate, the Bowditch phenomena, which may raise the per second transaortic flow and hence the aortic gradient. With an increase in contractility, you may get an increase in gradient. However, there are three pitfalls to tachycardia in AS. The rise in flow and the rise in gradient depends on whether the preload and therefore the stroke volume per cardiac cycle can be maintained despite a shorter diastole. They are more likely to be maintained during exercise where you get an increase in venous return and preload compared to the inappropriate tachycardia of pacing or tachyarrhythmia such as AFib. Number two, Bowditch is limited in LV dysfunction and inotropism and lusitropy increase up to a certain point but do not increase beyond 120 beats per minute, particularly if LVEF is also low. And number three, cardiac output is more specifically limited in AFib. In fact, AS gradient often decreases during AFib as AFib reduces the stroke volume and the overall cardiac output. AFib is a low output state, as I explained. Hence, it's important to distinguish fast heart rate from appropriate sinus tachycardia versus AFib. The gradient arises with appropriate sinus tachycardia but declines with AFib. And here is the most important slide that provides the target heart rate in various conditions. Number one, normal individual at maximum exercise, the target heart rate is about 220 minus age, in that neighborhood or 85% of that. Number two, heart failure with reduced EF chronically at rest in sinus rhythm, target heart rate less than 70 beats per minute. Heart rate with reduced EF decompensated or during exercise, heart rate up to 100 teens beats per minute. Number three, heart failure with preserved EF chronically at rest, target heart rate 75 to 100 beats per minute. Heart failure with preserved EF decompensated or at mild moderate exercise, target heart rate probably 100 to 120 beats per minute. Number four, AFib chronically at rest, target heart rate 75 to 100s beats per minute, even if heart failure with reduced EF. AFib with decompensated heart failure or critical illness, target heart rate 100 to 100 teens beats per minute, maybe 120 beats per minute in cases of high preload or maybe heart failure with preserved EF. Number five, a common question: what is the AFib rate that may cause hemodynamic compromise and require immediate urgent cardioversion? That rate is over 150 beats per minute in patients without heart failure, meaning those patients who have shock without massive pulmonary edema, or that heart rate is over 120, 130 beats per minute in patients with shock and heart failure with reduced EF, or that heart rate is over 130 beats per minute in patients with shock and heart failure with preserved EF.
One final summary note: tight rate control less than 70 has only proven beneficial in chronic heart failure with reduced EF. A rate of 100 to 100 teens may be optimal in exercise and decompensated heart failure with reduced EF, but Titrate control less than 70 is beneficial at rest in a compensated phase. Conversely, titrate control has not shown any benefit in stable CAD, hypertension, heart failure with preserved EF, or AFib, even AFib with heart failure and reduced EF. In fact, titrate control less than 70 using ivabradine failed to improve outcomes in stable CAD in a trial called Signify trial. Heart rate reduction less than 65 beats per minute with beta blockers in hypertensive trials was associated with increased adverse event rates.